ये वहीं रखो। हाँ
Good afternoon to all students, faculty, and esteemed delegates. We welcome you all to session 5 of the conference, the Young Investigator session. So it can be said that in every healthcare professional is the brain of a scientist and the heart of a humanitarian. So we learn so much from the talks in terms of science and innovation, but more importantly, as students, we learn from your humanitarian side. We learn from your passion towards healthcare, and we want to thank you for sharing it with the young future healthcare professionals that are sitting here today.
Research empowers young medical professionals to challenge existing norms, explore new ideas, and drive innovation in healthcare. By actively participating in research, young medical professionals can expand their knowledge and create critical thinking skills and enhance their ability to develop and provide evidence-based care. With this, I would like to introduce the chairs for this session, Professor Malcolm Walker. Professor Walker is a consultant cardiologist at University College Hospital, London. He is a professor of cardiology at Institute of Cardiovascular Science, University College, London, co-founder and clinical director, the Hatter Cardiovascular Institute, University College, London. He qualified in medicine from the University of Birmingham, United Kingdom, with cardiology training in London and Oxford. Appointed in 1987 as a cardiologist and physician at the University College Hospital, London, and elected as the Professor of Cardiology in 2019. In 1990, he established a dedicated cardiology clinic for the patients with disorders of hemoglobin, that is, sickle cell anemia and thalassemia. Following his experience in developing care for the patients with primarily non-cardiac diseases, he established a cardio-oncology unit at the UCLH. He has published over 120 articles and has a Scopus H index of 36. So can we have a round of applause for Malcolm Walker?
The next chair for this session is the president of the Cardiovascular Society of Mauritius, Dr. Baktuwa. A round of applause, please. Dr. Baktuwa, he obtained a scholarship from the Association of Graduates from USSR to study medicine and graduated with an MD from Vitebsk Medical Institute of Belarus. In 2008, he graduated as a specialist in cardiology from the University of Victor Secalen in Bordeaux, France. He is now a consultant in cardiology in the Ministry of Health and Quality of Life in Mauritius and a consultant in charge of cardiology at the JNH Cardiac Unit. So I'll ask you all for one more big round of applause for the founder, secretary, and current president of the Cardiovascular Society.
So the brief introduction for this session. This session will comprise of 5 talks, and the speaker has to complete the talk in the allotted time of 8 minutes, followed by a Q&A session of 4 minutes each. So with this, we would like to start the Young Investigator session.
So I'd like to call onto stage our first presenter, Isha Karkwad, for a presentation on global trends in CVD risk management due to smart wearable devices, a systematic review.
Good afternoon, honorable judges, respected teachers, faculty members, and my fellow participants. I am Isha Gaikwad, and on behalf of my team, I present my systematic review on the global trends of CVD risk management due to smart wearable devices. So, these are my team members, and introducing my topic. We know that cardiovascular diseases are the leading cause of death globally, and also major cause of both health conflict as well as economic suffering. And as the prevalence keeps rising, we need effective solutions that help in early detection as well as prevention of its risk factors. So, the innovation of smart wearable devices which help in detecting various parameters and also help in giving personalized guidance can be the future of prevention of CVD risk management. But the question arises, how can these devices help in CVD risk prevention? And to find this answer, we conducted a systematic review. Our methodologies followed the PRISMA guidelines and we used PubMed as our database. The inclusion criteria included full text English language randomized controlled trials in the year 2013 to 2023, and all irrelevant articles that failed quality assessment by copying English for past rules were eliminated. This is our Prisma table, and as you can see, we included 9 articles in our study. So, coming to the results. We have broadly classified the 9 studies according to the smart wearable devices that were used as an intervention. And starting with smart watches, we have a familiar device, the Samsung Galaxy smartwatch. It was used to track physical activity as well as monitor heart rate and blood pressure. It also gave personalized guidance to the participants. It was used as an intervention in hypertensive and pre-hypertensive subjects and showed a remarkable reduction in the blood pressure of the experimental group, which was greater than the control group. And second, we got Fitbit Smart Band. This had a similar function to the Samsung Galaxy Watch, and it was used to measure physical activity and track non-exercise physical activity such as counting steps and give daily reminders. This was used as an intervention in older adults with sedentary lifestyle, and the patients that tracked their non-exercise physical activity such as counting steps had a significant reduction in the systolic blood pressure as well as other risk factors for cardiovascular diseases such as cholesterol levels showed improvement. Moving on, we also have devices that could measure sleep, and this device, the bedded sleep tracker, used electrocardiography to measure minor movements in the body such as heart rate and breathing, and the sleep. And so this was a study used as sleep as a potentially modifiable risk factor of hypertension, and the outcome showed that increase in sleep led to a decrease in the blood pressure. This was also a study in different subgroups, so patients had different lifestyle behaviors and showed different outcomes. And this is the Activone Spectrum, which is a similar device to the Fitbit and was used to measure sleep efficiency. It also showed that the increase in sleep duration and better sleep quality led to a decrease in the blood pressure of the participants who were hypertensive. Moving on, we also have devices that were worn on the chest, and this is the XT adhesive patch. This is a miniature holder type device that was used to record 2 weeks of continuous ECG recording. And this was used as an intervention in older patients who had undiagnosed atrial fibrillation. And the results showed that it detected both paroxysmal as well as continuous atrial fibrillation and gave good quality ECGs. We also have another chest device, the R plus heart rate band, which was wirelessly connected to a health app, and it measured the exercise frequency, intensity, volume, progression, and time of the exercise. It also helped in determining the target heart rate of the patient, and it was used as an intervention in type 2 diabetes mellitus patients. The results showed that there was a significant improvement in the cardiorespiratory endurance, as well as decrease in the body fat percentage. Some patients also stopped taking the antidiuretic drugs after the intervention or had to lower their dosage. And lastly, a rather unique device called Digital Medicine Offering, or DMO. This is a device which consists of a digital pill and an ingestible sensor that on swallowing gets activated and sends signal to a wearable patch. This patch then sends data to a healthcare app, and the healthcare provider can access this data via the app to monitor the patient's medication adherence. This was an invention made to monitor medication adherence in patients with uncontrolled diabetes, mellitus, and hypertension. And these patients showed a significant improvement in their blood pressure after the intervention. And so to summarize, we can say that smart wearable devices are efficient and easy to use tools which promote an active lifestyle and give personalized guidance. They also help healthcare professionals like us in remote monitoring the patients, which decreases the hospital readmissions, ER visits, and also unnecessary doctor appointments, leading to lowering healthcare expenses and facilitates early detection, leading to early diagnosis and treatment. Also increase medication adherence and encourage the patients to self-monitor. Overall, they decrease the prevalence of cardiovascular diseases and hence also help in decreasing the burden. However, there are some limitations and challenges such as cost, as these wearable devices can be expensive. Ethical concerns regarding data privacy is another issue to be acknowledged, and patients must be informed about their data being collected. Dependency, as it can be misleading, and some patients might overlook their crucial symptoms which require medical attention. And lastly, our limited knowledge on these, as more studies are required to test their accuracy and reliability. Also, developing countries are lagging behind in these studies and its integration into current medical healthcare practices. And so to conclude, we can say that smart wearable devices have a significant role to play in both cardiovascular disease risk management and reducing economic burden. And although it is important to have more studies and need for quality products with affordable costs, these devices empower individuals to actively monitor and manage their CVD health and promote healthier lifestyle, enabling early detection and facilitating timely interventions. And finally, in conclusion, smart wearable devices are revolutionizing the future of cardiovascular disease risk management, and hence all healthcare professionals like us should encourage their use. These are my acknowledgement. I'd like to thank my mentors, my team, and SSR Medical College and references. Thank you.
Thank you very much indeed for a very interesting and well-presented talk. Thank you very much. Questions, please. We have a few minutes for questions. Questions from the audience, please. Okay, I have a question while you're all marshalling your thoughts and getting ready to ask important questions. This is the way we'll be able to grade these competitors. So please put your thinking hats on. I would like a question while the audience are thinking. How would you encourage the use and adoption of these technologies in a country such as Mauritius? What would you do to make it something that is more acceptable?
Firstly, it's, we can inform the people about their use so they are more aware about it, and also.
Good afternoon, sir. Thank you for the question. So first we find an objective of the use of the smart wearable, like for what we are using it, either for monitoring hypertension or AFib or like that. Then we find a suitable device that would measure those parameters that would be relevant for the monitoring of that specific disease or the risk factor. And then we will promote we will educate the healthcare providers about the devices, that how they can train the patient in using them, and only then we can make it available and affordable and accessible to the patient. Firstly, we have to know how to use that and what all it is monitoring and how all these parameters would affect their health. So in that way we can do that. Thank you, sir.
Regarding fibrillation. Now, how often should the patient wear the device? I don't know the device. And should it be worn 24-hour basis? And how long will last the battery? And how much costs the device?
This device is very good question, but and this device is very efficient and easy to use. It's just a patch that is worn on the chest, and it is wire free compared to the Holter. It is also water resistant, so it can be used during bathing and showering, and you don't have to remove it during sleeping also, as well. For the cost, it is quite expensive. It was around £340 in the UK. And what else did you have?
Sir, basically it is used for 2 weeks, and after that it is prescribed by the doctor to change the patch for the individual.
How many channel ECG can you report?
One. Single.
One channel.
Yes.
Any more questions? If not, thank you very much indeed and well done.
Moving forward, I would like to invite team 2. Please, can I invite Ranjam Sharma, who is a student of SSR Medical College, to present on the topic prerequisite screening of aspiring athletes to prevent a sudden arrhythmic death syndrome events, a systematic review. Can we have a round of applause for the team?
Good afternoon, everybody. Our judges, our faculty, and my peer students. Today, all of us are here collected for the International Symposium, and I, Ranjam Sharma, on behalf of my team with Brunda, Ankita, and Kriti, will be presenting on the topic of role of genetic screening of aspiring athletes in preventing a SADS event. SADS, sudden arrhythmic death syndrome. So for introduction, before I start, I would like to tell you about a case report that we came across while we were searching for material. And it was about a 12-year-old female gymnast who, while practicing, had a syncopal attack. On examination, there was no remarkable finding. Again, such similar episodes happened 5 to 6 times in the following year. After which, all of the cardiac profile was normal and she was misdiagnosed with epilepsy. On rest for another year and with treatment, she was better. After that, when she resumed her activities, she suffered through another attack, and then there was an implantable loop holder that was put, which again, while performing another stunt, recorded a change. And that is when they came across the fact that the spike only happened when she was exerting herself. So after 2 years of extensive tests, intensive treatments, and a lot of psychological distress, she was diagnosed with CPVT. And both her parents were negative, they tested negative for the gene, as well as there was no positive family history of sudden cardiac death. So quickly going through a few definitions that we would come across during the presentation. What is sudden cardiac death? So it is the rapid natural death caused by worsening of an existing heart disease. It results in instant mortality due to arrhythmia and ultimately arrest. For sudden arrhythmic death syndrome, it has been coined to categorically interpret the unexplained collapse, leading to death in the absence of any structural identification by an autopsy or even an toxicological examination. This brings in all the inherited cardiovascular disorders. One which concerns us is ion channelopathies. So again, what are these ion channelopathies? These are this rare group of inherited disorders, mostly all of them autosomal dominant in trait. Four major groups have been identified. These are long QT syndrome, short QT syndrome, Brugada syndrome, and CPVT, which is catecholaminergic polymorphic ventricular tachycardia. And such. It is an autopsy negative sudden unexplained death, which has been illustrated as death with absolutely no structural change in the myocardium or even a deranged toxicology report. When autopsied, they come to no relative conclusion and then presume it to be of an arrhythmic origin and label them as answered. So for material methods, we had the systematic review performed under the guidelines given by FISMA. Every full text has been indexed in PubMed with the keywords of athletes, channelopathy, genetic screening, and sudden cardiac death. For the data that we extracted, it included study origins, authors, sample size, study population, design period, and the outcome. For our PRISMA, out of 521 articles, we included 8 of them, which includes cohort comparative longitudinal study and other abstracts without full text, reviews, articles, and RCTs were excluded. Coming to the results, the earliest evidence is given by Marion BJ in a comparative study that spanned in a span of 31 years in a sample size of 2,406 young athletes, where STD was found to be the cause in 34.99%, of which ion channelopathy accounted for 2.13%, with the mean age recorded being around 16. Another one in USA, based by Marion BJ again, over the span of 26 years, 13 deaths were noted, 7 were due to cardiac causes, and there were 4 cases of answer. Again, the median age was 16. So in another USA-based comparative study spanning over a decade by Harmon KJ, he presented with 514 total deaths. The most common medical cause of death was STD in 15%, with a total of 16 deaths, which is 20.25% due to ion channelopathies. The only identified channelopathy was LQTS, and rest 15 were labeled answered. Here you can see that 25% of it is being labeled as sudden unexplained death. This is the number that we're trying to reduce. Another UK longitudinal study, the screening of adolescent soccer English Football Association, where all the players were aged between 16 years. Mean follow-up, after 10 years, there were 23 deaths due to cardiac disorders, out of which 35% were cardiac disorders, all of which were sudden and occurred during exercise. Of the 8 sudden cardiac deaths, 6 were in athletes who had normal findings during preliminary screening, including one of LQTS, which is again one of the key features for ion channelopathies, which shows that there is not a deranged ECG on finding. Further 2 case reports dating back to 2020 and 2021 were reported on SCTs due to CPVT and Brugada syndrome. In the most recent findings of a 4-year prospective study in USA by Daniel P., he shows that there have been 173 deaths due to STDs, and out of 141, 20 were accounted for ANSATs, 9 for LQTS, and 2 for CPVT. So a better look into the incidence in accordance to the demographics and respective age groups. 55.5% was noted in between 14 to 18 years of age, followed by 17.4% in 19 to 29-year-olds, followed another by 16.8% in 11 to 13 years, and 10.4% in former athletes. So in accordance to the Heart Rhythm Society and the European Heart Rhythm Association, expert consensus statement of August 2011, multiple types of channelopathies were compared using comprehensive or targeted gene testing in the categories of diagnostic, prognostic, and therapeutic. Here it is quite clear that the LQTS and CPVT have a greater diagnostic and prognostic impact than Brugada syndrome. Irrespective, it is completely necessary for us to diagnose these in time to prevent the deaths of young athletes. So we concluded all the data that we gathered into a total of 421 applications were screened from the year 1980 to 2018, of which 1,079 deaths were allocated to sudden cardiac death. SADS was considered as the cause of 73 deaths. Now, out of all the iron channelability, which is 52.5%, 81.5 was LQPS, CPVD was another 10.5, only 2.6 for the Chivari syndrome, and 6.45 for the other iron channelabilities. So, in conclusion, iron channelopathies, they account for a subtle but significant number of SPDs. LQPS being the most remarkable diagnosis. However, a substantial number of cases they remain undiagnosed even on autopsy and are labeled as cancer. This is the number that we want to reduce. Forthcoming evidence showcase the predominance of incidence in the younger populace in the developed countries and a prerequisite genetic screening. It addresses the predicament of unexplained deaths and thus is pertinent in shielding the younger populace. I would again like to emphasize on the objective of this paper that screening is not only done here to reduce the number of deaths, but also provides a medium for us to alter the athletic training and thus is pertinent in safeguarding the younger athletes, as our aim is not to limit their talent, but rather tailor it to their need. Thank you.
Thank you very much for this exposure. Yeah, questions are invited from the floor, please.
Thank you very much. It was my question. Very interesting talk. Now, regarding genetic testing, which you advise to be done in high-risk subjects for sudden death. We don't want them to go in the arms of the police medical officer for autopsy. So before necropsy, we would like to have live individuals. So once we screen, where would you advise for these genetic testing?
So, I'm sorry, to reiterate your question, are you asking the diagnostic centers where they are?
Yes.
Okay. So there is a site called www.genetest.org. It's continuously updated and it's publicly funded. It basically tells you all the genetic tests and all the genetic testing sites or centers that are available all over the world, and it's available to anyone online. And in USA, there are 3 genetic centers that you can do this in: GenX, Diagnos, GeneDx, and Collagen Diagnostics. In UK, there is St. Mary's Hospital in Manchester, and in Germany, there is one in Rostock, Institute of Human Genome Diagnostics. I'm not sure the name.
And in Mauritius, do we have facilities for this testing?
Not
Okay, let's hope we get it.
Any more questions? How many tests would you predict you'd need to do in Mauritius? How many high-risk individuals wanting to pursue an athletic career do you have?
That's what you're asking, sir. You're asking a number of high-risk populations.
Trying to get back to the question as to what the implication might be. How many?
Again, firstly, the interested populace, obviously, the more people who are in the exertional exercises, that is one thing. And again, we would like to focus, since it is an inherited disorder, if there's any background of positive family history for any sudden cardiac death.
One more question.
It was a very nice presentation, thank you. What's the status of implantable defibrillators in Mauritius? And if there's a family history and you diagnose an arrhythmia, is that an option in Mauritius?
No, we are not aware right now as in what is the state of any genetic on this podcast. So due to lack of evidences, our studies and our research was primarily restricted to UK and US because these are the two most common countries where they have done most amount of research in regards to this. There were not many studies done, none in fact. So we had to go with competitive technology.
One more question.
Yeah. Very nice talk. Thanks for sharing. Just a question, like genetic testing, of course, if you have known variants that predispose someone, of course, it's very easy to say that, you're probably going to have long QT or HOCM or something. But as you mentioned, your case study of the gymnast who didn't have any mutation in the parents, when you have these de novo mutations that do pop up, then how do you think you're going to diagnose that might actually be pathogenic variant or asymptomatic variant, and then how would you have any sort of approach to sort of get a better understanding on this? Thanks.
How we would consider the population that needs to have a positive family history of sudden cardiac death, especially under the age of 40, and who have undergone exercise, especially exercise induced. And on routine cardiac evaluation, if there is a specific ECG finding, like for long routine ECG prolongation, for regard that there's a characteristic folks, esteemed elevation. As of now, we would consider this.
Thanks.
So also if there is a de novo mutation that is found, obviously if a person has been diagnosed with LQPS, it is assumed to be an autosomal dominant one. So the parents and the family members are also genetically screened. If it is found to be negative, then it's considered to be a de novo.
We better move on. Thank you very much.
Thank you for that wonderful talk. Next, let's please welcome Seewoosagur, presenting an assessment of medical intervention in transcatheter aortic valve implantation patients, a systematic review. A big round of applause for her.
Good afternoon, honorable judges and faculty members and dear audience. I'm Justus-Liebig-University and my topic is assessment of medical intervention in transcatheter aortic valve implantation, a systematic review. First, we need to know a little background about TAVI. What is TAVI? It is a minimally invasive procedure where a new valve is inserted without removing the old damaged valve. It is done in those patients who are intermediate to high risk of invasive surgery. However, few data exist on the optimal therapy following TAVI that adequately balances thromboembolic events and bleeding hazard. Thus, it remains an important question to be answered, what is the optimal therapy? For the methodology, as to the pre-control, we use the PubMed database, and using our keywords, we found 291 randomized controlled trials, and out of which we selected 6 for our systematic review. The first one compared aspirin with or without clopidogrel after TAVI. Current guidelines recommend aspirin along with TAVI for the first 3 to 6 months after TAVI in patients who do not have an indication for oral anticoagulation. This is because during the first 3 months of the TAVI, the patients are at high risk of stroke. Hence, the control group was the standard regimen aspirin plus clopidogrel and the intervention group was aspirin monotherapy. Here, our main findings were a bleeding event occurred in 50 patients in receiving aspirin alone and 89 patients receiving aspirin plus clopidogrel. These values were statistically significant, and the thromboembolic event was comparable in both the groups. Hence, we can see that the intervention group had a lower bleeding rate than the control. The second one, we compared oral anticoagulation with or without clopidogrel after TAVI. In patients who have a long-term indication for oral anticoagulation, the current guidelines recommend either anticoagulation with or without clopidogrel. And here the control group, we choose oral anticoagulation monotherapy, and the intervention group, we chose oral anticoagulation plus clopidogrel. However, they can be interchangeable. And same they were for the first 3 months because they were at high risk of thromboembolic events. Here, our main findings were bleeding occurred in 34 patients receiving oral anticoagulation alone and 54 patients receiving oral anticoagulation plus clopidogrel. So we can say that here again, the monotherapy had less bleeding event compared to the dual therapy, and the thromboembolic event was comparable in both the groups. For the third one, it was on assessment of platelet reactivity. A high platelet reactivity is a high risk factor for stroke. Hence, for both the control and the intervention group, we chose, it was given dual therapy. And the control group was the standard aspirin plus clopidogrel, and the intervention was aspirin plus ticagrelor. And our main findings, we found that ticagrelor plus aspirin had a lower platelet reactivity than clopidogrel plus aspirin, suggesting that it had a lower risk of thromboembolic events, and it had a similar lower bleeding event with ticagrelor plus aspirin with 4 patients compared to clopidogrel plus aspirin with 7 patients. However, the differences was not statistically significant with a p-value of 0.49. The fourth one compared apixaban versus standard of care of the TAVI. Here, the standard of care was either oral anticoagulation or antiplatelet therapy. Hence, it was subdivided into 2 strata. The stratum 1 was one with an indication for oral anticoagulation. Hence, they were given a vitamin K antagonist, and the strata 2, they were given antiplatelet therapy. And the intervention for both the groups was apixaban. Here we found that a bleeding event occurred in 174 patients receiving apixaban and in 170 patients receiving the standard of care. And a reduced subclinical valve thrombosis was also found in the apixaban group. Here we can see, as in the graph, both the stratum 1 and stratum 2 had comparable bleeding events. The fifth one compared edoxaban versus vitamin K antagonist for atrial fibrillation as the indication for the oral anticoagulation. And here the control group was the oral anticoagulant vitamin K antagonist, and the intervention group was edoxaban. And we found that major bleeding occurred in 98 patients in the edoxaban group and in 68 patients receiving the vitamin K antagonist group. Here, the intervention group had a higher bleeding rate compared to the control, as it was associated with more GI bleed, which was significant in the edoxaban. And for the last one, we a randomized control trial compared rivaroxaban after TAVI, and the control group was the standard clopidogrel plus aspirin, and the intervention group was rivaroxaban plus aspirin. Here, our main findings were major bleeding occurred in 46 patients in the intervention group and in 31 patients in the control group. However, the difference was not statistically significant, and the randomized control trial was prematurely terminated because rivaroxaban was associated with a higher risk of thromboembolic event, along with a higher mortality rate than the control group. And to conclude, we found that the single therapy was preferred for its lower incidence of bleeding comparable to the thrombotic events compared to the dual therapy. And in case where the patient required dual therapy, who has an indication for antiplatelet therapy, ticagrelor plus aspirin was found to be preferred compared to the standard regimen, clopidogrel plus aspirin. And the factor 10A inhibitor of choice was apixaban with less bleeding and less adverse effects compared to rivaroxaban and edoxaban, where rivaroxaban was associated with a higher mortality rate and edoxaban was associated with more GI bleed. And I would like to take this opportunity to thank the organizing committee who organized this session for us, and thank the judges. And these are my references. Thank you.
Well done. Thank you very much indeed. We have some minutes for questions, please.
Thank you, Dr. Ramban. Dr. Ramban is from Kotak Center. Do you have any idea how many cases have been done?
In 10 of March 2023, the first intervention of TAVI was carried out by Dr. Sunil Ganesh, and it was...
No, it was Dr. Kapil Lotan. They came from
yes,
yes, 4 cases.
Yes. Four cases have been carried out as from this year.
They are doing 10.
Yes. Okay. Thanks.
So Dr. Kapil Lotan is from USA. So this is the second time that he's coming to Mauritius for TAVI purpose. So last time they did 4 TAVI cases, and apparently this time 6 more have been done. Dr. Lotan itself, because he is a proctor. So aspirin and clopidogrel mainly. In case AF, then he's putting on warfarin. For 6 months at least.
Can we address the questions to our presenters? Any questions for our presenters? I have one. From your reading and your excellent presentation, you are suggesting there's a difference between rivaroxaban and apixaban and edoxaban. Is there anything from your reading to give us an idea of what the mechanism might be?
So the mechanism of action of all of these three is that they are direct factor 10A inhibitors. But each of them have different specific adverse effects, such as rivaroxaban was associated with a higher mortality rate. Edoxaban had higher GI bleeding, and apixaban, although it is preferred compared to these two, it still had bleeding tendencies posterior.
Very nice presentation. There's obviously a lot of interest in factor 11 inhibitors from pharmaceutical companies. Are you aware, are there any studies planned to trial factor 11 inhibitors given the bleeding problems in these patients?
Sorry, I couldn't understand the question.
So factor 11 is a very attractive target because people who don't have factor 11 tend to have very mild bleeding problems. So there are many factor 11 inhibitors in advanced stages of development. I'm wondering whether there are any trials looking at factor 11 inhibitors in these patients.
We did not come across factor 11 in our study, so we are not sure.
We have time for one more question, a fast question and a faster answer. Any more questions? You've been let off the hook. Thank you very much indeed.
Thank you so much for the presentation. Now, I would like to invite team coach Akshay Satish, student of SSR Medical College, to speak on a systematic review of PCI and CABG in chronic coronary syndrome, unraveling their impact on long-term survival and disease burden. Can we have a round of applause for the team fourth?
Good afternoon, ladies and gentlemen. Today, our team BioMinds has actually tried to answer the age-old question when it comes to revascularization strategy, percutaneous coronary intervention or coronary artery bypass graft surgery. Firstly, I'd like to extend my gratitude towards our chairman, sir, our principal, sir, and the organizing committee for giving us this forum to broaden our knowledge on cardiology. So we try to answer this question through a systematic approach in terms of understanding the short-term and the long-term outcomes in patients of chronic coronary syndrome, suffering from chronic coronary syndrome. So before I dive in deep into the paper, I would first like to cover the facets of this presentation. So I'll be walking you through the background of the paper, the purpose, the methodology, results, conclusion, and followed by our references. So the fundamental motivation behind as to why we did this trial was, if you look back in time, some pivotal trials, such as the Barry trial and the Syntac trial, signal towards bypass being superior to PCI, especially in terms of in terms of mortality. However, there has been recent advancements in stent technology. So if we were to do the trial now, that is post the drug-eluting stent era, we wanted to know if you would find any significant findings, would there be any changes, and still would CABG be superior to PCI in terms of mortality. The key components of our comparative analysis were short-term outcome, that is within 1 year of the procedure, and long-term outcome, that is within 5 to 10 years of the procedure. So how did we approach this research? We set out for an analysis and built our data with PubMed under respective mesh terms, inclusion and exclusion criteria in accordance with PRISMA guidelines, and gathered about 14 randomized controlled trials that was published 10 years ago. And in total, the number of subjects that we gathered was around 35,122, in which 15,811 opted for PCR and 19,311 opted for CABG. It was then succeeded with a robust statistical analysis with the help of STATA software to obtain hazard ratio, confidence interval, and central tendency values. So as you can see, we started with around 13,000 trials, and then we boiled it down to 14 trials with respect to the criteria and the inclusion-exclusion criteria with respect to the PRISMA guidelines. We also assess the quality with risk bias too. The low overall indicates high-quality studies with minimal bias, while the high overall suggests less reliable results due to significant bias. Unclear overall risk reflects uncertain quality due to either lack of information or incomplete information. After fine scrutinization in this study, we tried to impart individual endpoints rather than composite endpoints to forward the cumbersome approach that we take towards treatment. So under individual endpoints, we further subdivided them into primary endpoint and secondary endpoint. Under primary endpoint, we mainly focused on the 3-point main system and then repeat revascularization rate. And under secondary endpoint, we focused on angina relief and median hospital stay. So let's look into primary endpoint. Firstly, under primary endpoint with respect to all-cause mortality rates, it was similar between both the groups, with p-value being equal to 0.013. And in terms of occurrence of MI, that being non-fatal MI under the 3-point mains, PCI had increased rate of occurrence. But however, if opted for a complete revascularization, the rate of occurrence between both the groups was similar.
Coming to overall MACE rates. Overall MACE rates were actually lesser in CABG, especially in long-term duration, with hazard ratio being around 1.18 at 95% confidence interval. And with respect to repeat revascularization, PCI significantly has a higher rates with hazard ratio 1.15. However, there has been a decent declinement of trends as recent advancement of PCI approach our healthcare facilities. On the basis of secondary endpoint, where we consider to be more subjective in perspective, secondary angina relief was better in CABG and in terms of median hospital stay. That being the number of days the patient stays back in the hospital immediately post the procedure was lesser in PCI, making the patient up and going sooner. We also conducted a subgroup analysis between two main risk groups, that being diabetics and elderly patients, especially above 70 years of age. Among 3,109 states and lesser repeat revascularization rate. And among 575 elderly patients above 70 years of age, the hazard ratio between both the groups, PCI and CABG, had similar hazard ratio in all facets. Now, to understand the management of not only the average syntax score, that being 22 to 33, also for the patients who lie on the lower syntax score and the higher syntax score, we further extracted our studies. And we found out that in case of lower syntax score, PCI and CABG had similar event rates, and in case of higher syntax score, CABG had lesser event rates. Irrespective of the syntax score, repeat revascularization rate was higher in both the groups. Moving on to the discussion part of the paper. Firstly, long-term outcome and MACE rates. CABG shows significant advantage by lower MACE rates within 10 years of the procedure, highlighting for a more potential sustained benefit. And in case of balancing mortality and quality of life, there has been comparable survival rates. However, since CABG has better angina relief, we are looking more towards a holistic approach when we treat a patient. In terms of repeat revascularization and durability, PCI still seems to actually cause a conundrum due to its higher repeat revascularization rate. However, there has been a significant decline in the rates over time as there's been advancements in the stent technology field. With respect to subgroup and personalization, personalized choices are recommended, especially in patients who are diabetic and in patients who have higher syntax score, where CABG seems to be a mainstay treatment. And in case of elderly patients and lower syntax score, PCI is now seems to be a reasonable choice. Now, future research should focus on trials being performed on newer generation stents along with factoring in patient characteristics and coronary anatomy. Implications of this paper include optimized treatment choices based on patient characteristics and complexity of the coronary anatomy, prevailing towards a more resourceful field and a cost-beneficial area. Our study limitations include a non-crossover trial between PCI and CABG, and also smaller subjects for subgroup analysis and more. In the current era, what is the take-home message is that in the current era, CABG may still offer better long-term survival outcome compared to PCI for patients with chronic coronary syndrome and in between the average syntax score. However, there is a notable trend towards improved results, especially after the introduction of drug-eluting stents. So these are our supportive data and references. So before I end my presentation, I would like to personally thank Dr. Banerjee and Dr. Sabane for bestowing their knowledge upon us, and an extended gratitude to Dr. Bharatraj Kitambi, who's been a valuable support to our research. Thank you.
Okay. We'll all take a breath. Well done. Any questions from the audience? Any questions from the audience? Now at the poster, you had a very nice device that would help clinicians. Can you did everybody see the poster? They had a dice with patient characteristics, which anybody viewing the poster had to throw the dice, and then you would tell us what would be the best approach. Do you think that is something? We all have apps on our phone. You all are very good with phones and apps. Are you going to design one so that the clinician can say, oh,
So we were actually thinking of designing an app called Cardio Choice, where you just enter the patient's characteristics, the syntax score, the comorbidities that he has, and then based on our research, because systematic review being a more of an advanced research compared when we see the hierarchy. So we wanted to be like it would give an idea even to the patients as well as to the clinicians. So yeah.
brilliant, thank you. Any other questions? You've silenced your. Thank you very much indeed.
Thank you for that talk. And our last presentation for this session is the role of natriuretic peptide in predicting adverse outcomes amongst patients with atrial fibrillation, a systematic review. And so for this last presentation, I'd like to call forth Shorvik Walia from Team 5.
Good afternoon to one and all present here. This is my first time speaking in front of such a huge audience. Don't get me wrong, this is great. Okay. This slide gives you a basic overview of the objectives that I'll be covering in this presentation. I'll begin with sharing some basic information on the subject and continue through the following bullets listed on the screen. A study in 2012 done at the Medical College of Wisconsin stated that approximately 25% of the individuals aged 40 years and older will develop atrial fibrillation during their lifetime. AFib is the commonest arrhythmia known to men. It is mostly seen in people aged 60 or above, and a majority of them being men. It is most prevalent in North America and parts of Brazil and Western Europe. As the numbers continue to rise due to growing elderly population, increase in individuals with hypertension and diabetes, and nicotine and caffeine being consumed the most they have ever been, various management strategies need to be explored to find the cost-efficient method of controlling AFib and its outcomes worldwide. Recent research is starting to investigate the impact of natriuretic peptides in assessing outcomes and the progression in patients with atrial fibrillation. Now, natriuretic peptides are structurally similar proteins and they act as diuretics and natriuretics. The family of natriuretic peptides include ANP and BNP, which are cardiac hormones. They are involved in control of chronic hypertension. And CNP is a paracrine regulator. So it's not involved in the study. Our study will basically focus on beta natriuretic peptide or its inactive form, which is called N-type of brain natriuretic peptide. The reasons for choosing BNP over ANP were that BNP is more hemodynamically stable. This is because it is more resistant to the clearing factors of the body. BNP has a longer half-life, which is of 21 minutes as compared to ANP, that is of 2 minutes. And BNP goes back to the baseline as soon as sinus rhythm is achieved. This brings us to the question I'm trying to answer in the systemic review, which is what is the role of natriuretic peptides in predicting adverse outcomes among patients with atrial fibrillation? The protocol of the systemic review was designed and conducted and informed followed PRISMA guidelines. RCTs, controlled clinical trials, randomized double-blind controlled trials, and cohort studies were included in the eligibility criteria. We conducted a systemic literary research on PubMed using two separate search queries, which are listed right here, this one and this one. Um, the initial search yielded 554 articles, out of which 251 were unique articles. Out of these, titles and abstracts were screened, and we excluded 133, resulting in 64 articles entering full text analysis. We excluded majority of them as some of them were correlated to renal failure, some were correlated to thoracic surgery. In a lot of them, no cutoff value was given, non-clinical trials were included, and not enough data was reported. The data collection was done using Excel sheets. The different criteria being author, year, sample size, mean age, BNP level, hazard ratio, p-value, and study design. This made it easier to compare the studies as a whole and determine the commonalities and differences. In the next few slides, I'll be discussing the synthesis and comparison of the results of this subtopics, which being stroke, heart failure, and recurrence. Atrial fibrillation and the risk of heart failure. 3 studies examined BNP and NT-proBNP in atrial fibrillation and heart failure. Here I have a box plot showing NT-proBNP concentration in different patient groups. On the x-axis, I have all the phenotypes of the patients, and on the y-axis, I have the NT-proBNP concentration. As we compare the plots of the control group, which is people with neither AFib nor heart failure, to patients having AFib and heart failure, if you look at the lower whisker for the control group, it starts at 71. But for patients having both AFib and heart failure, it starts at 600, which is a huge jump. And if we compare the upper whisker, in the control group, in the fourth group with patients having atrial fibrillation and heart failure, it goes all the way up to 4,000. And compared to patients having only AFib and only heart failure, it is almost 2,000, 3,000 picograms per ml more. This proves that BNP increases multiple folds with when atrial fibrillation patients progress towards heart failure. Here is a Kaplan-Meier curves plotted for composite outcomes at 2.5 years of follow-up time. The red lines here indicate the pro-BNP level of more than 2000 picogram per ml, and the black lines or the blue lines are less than 300 picogram. Now, if we zoom into the fourth plot, we can very clearly make out that the patients with higher natriuretic peptide values were at a higher risk of composite outcomes over a follow-up time of 900 days. Now, this slide very beautifully concludes whatever we talked about in the previous few slides. 1,616 consecutive patients with heart failure were classified and monitored for 2.5 years for heart failure hospitalization and cardiovascular death. In the line graph, the people with the atrial fibrillation and heart failure are represented in orange, which is right here. Compared to the control group, they are at a higher risk of composite outcomes over time, almost by 500%, and 150% more than the group having only atrial fibrillation. The table here displays the range of heart rate hazard ratio in patients with a different level of NT-proBNP. In the group with only AFib, using NT levels more than 300 gives us a hazard ratio of more than 4. And as the NT-proBNP levels increase, so does the hazard ratio. This proves that that NT-proBNP can predict future risk of heart failure hospitalization and cardiovascular death in patients with atrial fibrillation, irrespective of the presence of heart failure, even after adjusting for confounding variables. Atrial fibrillation and risk of stroke. We included 2 studies, the first study being including 261 patients with median age of 74, and the second study including 1,177 patients receiving anticoagulation therapy. Here I have a 3D bar graph of the first study. This graph represents the occurrence of stroke and systemic embolism in relationship with NT-proBNP and CHA2DS2-VASc score on the X, Y, and the Z axis respectively. As you can see, as the NT-proBNP level increases, so does the risk of stroke or systemic embolism. And this trend is observed in every group of CHA2DS score, be it the group 2, be it group 3, group 4, or more than 5. This is the 3D bar graph of the second study, and it gave the same results as the first one. Now, lastly, atrial fibrillation and the risk of reoccurrence. What we observed was that anti-pro-BNP alone did not reliably predict AFib ablation success, but post-ablation elevation suggested a long-term monitoring. Now, a study done in China, which included 1,410 patients, the BNP with a cutoff of 237.45 picogram per ml was a strong predictor of AFib recurrence. The benefits of my studies are that the systemic review included a comprehensive literary search on the most recent evidence-based studies in the last 11 years regarding AFib and natriuretic peptides. The methods I talked about in this presentation would provide economical relief, better course of management, and our study had a good worldwide representation as we included studies from 4 different continents. The limitations of our studies are while natriuretic peptide levels are effective in diagnosis and prognosis independently, they are not universally acceptable, as the cutoff value depends on various patient factors. The methods in every study and every article vary, and the studies were very heterogeneous, so it's very hard to pinpoint a specific cutoff value for every adverse outcome. Further research in this field is...
We'll have to ask you to wind up now because
yes,
well
yes, sir. Further research in this study is necessary to fully harness the potential of natriuretic peptides. These are my references. Thank you.
Well done. Well done. Okay. Over to you. Any questions? Any questions? Okay, from your reading, if an individual with a certain level of BNP has an episode of atrial fibrillation, what happens to their BNP, knowing what you know about the physiology of why it raised?
Are you asking the physiology of AFib?
I'm asking about the physiology of what happens to BNP levels when people have a burst of atrial fibrillation. Have a guess.
So it would rise to a level of more than 100 pgmh.
And the reason?
So the heart produces more BNP in order to, so someone will...
It's atrial stretch. Any other questions? Thank you.
In one slide, you showed the 4 different groups, and in one of them you had, 2 of them, you had some extremely high data of your
Yeah, so
I know they come out of a big observation study, but is there any evidence that such excessive concentrations have any clinical significance?
Data has been cited from already published and reviewed studies, and a lot of exceptions, they are going above the level of 30,000 BNP, but if you look at this is the upper whisker, and this is the median. So above this, it's just a couple of exceptions.
Yeah, those and those and those. Is there
There could be a number of reasons. Could be that they must be very old and smoking, or they could have not been taking their anticoagulants.
But would such a high level have any clinical significance?
But it does. It shows the urgency in this patient. He needs to get himself checked out real soon, or he'll be in big trouble.
It may be beneficial. Any more questions? Okay, gentlemen, thank you very much. Can I just say one thing? I think we have to congratulate the entire group for some really, really excellent presentations. And I think compared to your seniors, the majority of instances, you will teach many people a lesson on how to keep to time doing a talk. So well done all.
Thank you so much for talking on in the Young Investigator session. We would like to invite Professor Derek Yeller to present the certificates to the chair. Professor Derek Hosenloy can come and do the honors for the chairs. I would like to invite Professor Malcolm Walker to receive a certificate.
And I'd like to call Dr. Bhaktwar to receive his certificate.
With this, we conclude the Young Investigator session. Thank you for your patience and active participation. Also, now we have the group photograph that will be just outside the main hall, and the volunteers will guide you. So first, the international delegates are requested to move for the photograph, followed by the members of the Cardiovascular Society and the cardiac centers. And then we can have the SSR faculty and the organizing committee. And also, you can give your valuable feedback to us through the QR code that is placed on this table. And the photograph will be followed by lunch. And then in about 30 minutes, we will resume the conference. Thank you.